Hello. Can you guys hear me okay? Yes? Good. It's an honor to be here today speaking to all of you. I think over the past 10 years that I've been working in LGBT health, and I know that many of you have worked in it for far longer, it just is more and more exciting to see the number of people who are invested in training and providing quality care for LGBT individuals. So I really, really appreciate each and every one of you coming out here. So the main points of my talk at the end of the day, they asked me to just speak a little bit about change, how organizations change, how curriculum can change, how we can change as people to do things in a way that meets the needs of the communities that we're serving. So across, largely speaking, I'm going to be hitting on some main topics. I'm just going to talk broadly about research. I know, are any of you like researchers, like even quality improvement? You look at patient outcomes. Okay. Well, oh, hi. Hey, research folks. Also, throughout this talk, I just want you to know, if you think something is funny and you can't quite tell if I'm making a joke, chances are I'm making a joke. I just have a really dry sense of humor. So just go ahead and laugh. And if it wasn't a joke and you laugh anyway, that's fine too. It's good to smile. So some of you do research. Hopefully what I can kind of inspire you to do if you don't do research is to think about how you might want to collect data to evaluate the outcomes of what it is that you do. I'm going to talk about education. My experience is largely within the training of physicians, but when we say the Association of American Medical Colleges, that's the regulatory body over medical schools and residency programs. There are similar bodies over nursing, over physician assistants, over dental schools, across the board. So what I will be talking about is applicable to each and every one of you who's involved in healthcare training. And lastly, advocacy. I think I'm going to give you just an example of something that we did at Vanderbilt that was pretty cool. I certainly don't think that it goes above and beyond the amazing work that Persad is doing, that Metro Health is doing, that adolescent medicine is doing. It's just an example of how we could create change at Vanderbilt within the institution. Working with the institution and what they saw for their goals and what we wanted for our community. So again, this is all just kind of a broad overview. I'm fine if you have a question in the middle of the conference and just want to yell it out. I'm more than happy to stop and talk about the things that you guys have questions about, because if you guys have questions about them, then it's worth spending some time on, because hopefully you can take it back to wherever you are. I guess I don't need, usually I just kind of put this slide up here because I don't get a phenomenal introduction, but thank you, Amy, for that introduction. Instead, I'll say I was born and raised in Maryland, in Rockville, and I have a dog, and sometimes I sleep. So everything else you already heard. So I think it's also really important when we think about LGBT healthcare is to really think about how it's evolved over time, because even in the past 20 years we've seen changes in the way we use LGBT as an acronym. What letters do we need to add on? Are the letters enough? Maybe we should use different language. So you see a lot of fluctuation in how we describe our community. And I think it's really important to acknowledge that change also parallels many of the changes in healthcare as well. So I just find this fascinating how this kind of came to be. So initially, like prior to maybe 1850s or so, any kind of same-sex sexual activity, primarily among men, because women didn't have sex before 1920, you could be arrested, you could be put in jail. It was illegal. And over the course of the second half of 1850 to 1900, neurologists and psychiatrists out in Europe said, actually, and this was groundbreaking at the time, they said, wait, maybe this is a disorder, so you shouldn't criminalize it. And that was an advancement to say, well, it's a disorder, so we don't have to throw people in jail. So that classification of homosexuality as a disorder actually led to some legislative changes that kept people out of prison. So not exactly what we think of as an advancement, but at the time it was. And the conceptualization of sexual orientation at that time, homosexuality was not really a term. The people that they described as having, as what we now might say, an individual who is gay, at that time, if they were feminine appearing and they had sex with men, that generally was classified, called with the term of sexual inversion. And so if you think because they felt like that person wanted to be a woman, therefore, because they wanted to have sex, like insertive sex, that they probably wanted to be a woman, and it's sexual inversion, and that's the disorder. So you can see, like, automatically right at the beginning of when these issues started to become more public and more talked about, they were really confusing gender identity. They were really confusing sexual orientation. They were confusing gender expression, and we just lumped it into one thing that we classified as a disorder. Over time, the United States, a lot of activists in the United States started pushing back, and medical society started pushing back, saying, you know what, this isn't a disorder, this is part of normative behavior. And so that's early advocacy work, where they did these little magazines, publications that really tried to push medicine forward. This was around the same time. I'll just say at this point too, this is when, for those of you that do mental health care, this is when the DSM was really coming to, was being utilized. It was developed and utilized a lot more, where homosexuality was in the DSM, at least in iterations, I think 3, and it was in 1973 they changed the iteration where homosexuality, they removed it but put ego-discordant homosexuality. So if you were gay but didn't like it, it was a disorder. And then in 1983, which is incredible to me because that's the year that I was born, that's when they took it out as a disorder, okay? So all of this has been quite recent. But medicine itself, not just in terms of thinking about things as what's a disorder, what's not a disorder, surgeons at the time were also developing techniques for any kind of cross-gender surgical care. And so in 1952, that was actually when the first genital reassignment surgery occurred, and with Christine Jorgensen, who was quite famous at the time for this. But so as you can see at that point, we have a disorder, but we also have people engaging in treatment. So the classification of a thing as a disorder as well had people thinking about how could we provide care to this community? How could we help this community? I will say the things that we came up with were also relatively barbaric. So, electroconvulsive therapy, injecting people with hormones. At one point, I can't remember what country it was in, some like European country, they thought that if you implanted rat testicles in a male, that might cure it. It didn't at all. So we don't put rat testicles in people anymore. But progress, live and learn. This is why research is important. Sorry. And then over time, one of the things that then occurred as well is we had to push more towards thinking about, what is sexual orientation, what is gender identity, thinking about them as constructs. What is womanhood? What does it mean to be female? And really pushing back on sort of the constructs of what are we trying to define. And then in the mid-'70s, that was when our first LGBT health centers that we know of around the country, Fenway, Howard Brown, the Mazzoni Center out in Philadelphia. These are when the first healthcare organizations were founded. And it wasn't until the HIV sort of came out as an epidemic that mainstream medicine really started to recognize the gay community overall. And since that time, we've been making progress in a lot of different ways. We have made a lot of progress with how we do surgeries. We've made a lot of progress in how we do dosing of hormones. We've made progress in terms of how we screen for cancer. So there's a lot that we've done over the past 50 years or so that has really advanced the health of the LGBT community, and it's really exciting to see where it's going to move forward. So moving into the present, one of the ways when I think about this topic overall, we say LGBT, I will continue to say LGBT, but as a clinician, when I think about how I'm talking with someone about their sexual orientation or their gender identity, is I actually like to try and break these things down and say, in terms of sexual orientation, who are you romantically, attracted to, and then what do you do with them, and then gender identity, but also gender expression. So one of the cool areas of research that's up and coming right now is looking at gender nonconformity, which is also something that we don't typically think about. We say trans kids, but there's a lot of people out there who are gender nonconforming who also experience a lot of bullying, potentially for being gay, and maybe they might be gay, but maybe they might not be. So we're looking at gender expression as well. So that's something to also consider. And then sex development. I'm not going to talk much on this topic, but suffice to say that when something changes, whether it's a structural anomaly, an endocrine deficiency, or something else that might disrupt the normative development of maleness or femaleness that we would say XX or XY, something along those lines. You can have a variety of presentations of sex, and people with differences of sex development are markedly, we always throw I in our acronym LGBTQI. We rarely do the I any justice because in many ways we just, they're very different things. They're just very different. So I encourage you when you use the term LGBTQI, I really do encourage you to think about what are you doing for the I, and is saying something appropriate for the LGBT community, is that appropriate for the I community? Because I think the last thing that our community wants to do to a different community is sort of say, hey, we're speaking for you, this is what's right, okay? So I'm just going to encourage you guys to think about that if you throw the I into the acronym, because you want to be culturally competent. Unless you're doing something to address it, you're probably not. So overall, in terms of history, from a research standpoint, it was also really in the 50s as well when people started thinking, okay, how can I measure orientation? How can I measure what people are doing? And the idea of homosexuality or same-sex sexual behavior was considered quite rare. And that's when Kinsey started doing his research, and the Kinsey reports came out and found that, oh, well, really, it turns out that about 10% of the population, depending on your age range, that varies, but about 10% of the population has had some experience with same-sex sexual activity. So again, that's not to conflate being gay, but you have a group of people who are engaging in same-sex sexual activity, and that was strikingly more people than anyone anticipated. And so then they started, well, they're like, oh, if this many people are doing it, we should probably research it. And it's fair. I don't know why they didn't go for experiential research. It's a joke. That was one of them. So, they instead tried to create scales. We tried to create sort of numerical things that would help us calculate like your percent gay. Again, Science has its flaws. So we created a variety of methods for, scoring your sexual orientation or your gender. So you have like the BEM sexual inventory. All of these are actually strikingly outdated at this point, where now what we try and do in research is really think about how does someone define themselves related to their sexual orientation. One of the important things to consider is, again, there's a variety of people who engage in same-sex sexual activity that do identify as straight, or younger kids where they may come out as gay or bisexual over time but don't identify yet. There's some nuances in how we ask the question, but typically we now go with identity and how people choose to disclose. And so we have sort of a behavioral self-disclosure. So what do you do with people? How frequently are you doing it? All that stuff. Are you doing, what gender person are you doing? And then you have identity disclosure. How do you define yourself? And so when we think about these things differently, the disparities actually change a little bit. So when we think about moving forward with research, and when I say this, I actually just think about how you might want to, again, collect information. So how many of you are collecting sexual orientation, gender identity information? That's awesome. So, we collect it. There's a variety of ways to collect it. How many of you are analyzing that data? That's so cool. But still, okay, but progress. I like data. So overall, we have, if we're going to collect the information, we should use it, we should look at it, because that gives us a really good picture of on the ground what is happening in our various local communities, as opposed to sort of these national samples, which sometimes we use as well. But again, there's a lot of regional variability and disparities too. So overall, when we're thinking about how to quantify the experiences of the LGBT community, I'm just going to throw out a couple of ways in which people tend to think about it and how they're trying to incorporate these into research. The first one is one that's been used for a long time. It's the minority stress model. It was adapted. It's not necessarily specific to LGBT individuals. It's, for any minority person, but you have to understand the disparities, essentially the disparities that are faced by that community. So you can apply it, it's been applied to the Black community to look at essentially threat bias. So thinking that people, if someone sees you, how do you and how much of that sort of internalization of their reaction do you feel like it's due to race? We do the same thing in the gay community in many ways, where we attribute someone's reaction, whether positive or negative, potentially to our sexual orientation or gender identity or gender expression. And that can lead to a lot of these what's called proximal processes, where you expect rejection, you expect people not to like you, you conceal your identity in certain situations. I remember I've been out for longer than I haven't been, which is also really neat. And at the same time, I remember when I was leaving college and going to my first job, it was like stepping back into the closet, and that was the first time I sort of had that realization of like, oh, I'm going to have to do this a lot, as I move and as I meet new people. And so that process of concealing your identity, and I didn't come out for a year, actually there. I'm sure they knew, but, no one else brought it up either. It's kind of hard not to. And then internalized homophobia, kind of hating yourself or disliking yourself because of your sexual orientation, or internalized transphobia because of your gender identity. And obviously, we all know that discrimination, bias, harassment, victimization are all greater in the LGBT communities. But these things, these stressors have to be taken against support networks and how you cope with things. And that's going to be what leads to the disparities in the community, both with mental health and with physical health. So I'll touch on those in a little bit. Was there a question? No? Okay. The other thing to think about too is intersectionality. It's really important to think about how different communities are, how sexual orientation and gender identity in different communities can change the health disparities as well. It's great when we look at the LGBT community as a whole, but when we're thinking about developing interventions, we have to understand, hey, in this community, like if you're, identify as LGBT, but actually, race is kind of the paramount issue. There's a lot of violence, and it's not related to sexual orientation, or, again, depending on these things, we really have to keep, like trans women of color, who's kind of like the, 3 layers of discrimination, who are so disproportionately affected by a variety of health conditions. So thinking about what are the other demographic variables that you want to include is important. A good example of this is percentage of individuals who use alcohol. So this is based on race. So what you can see here essentially is that when we think about alcohol use, potentially alcohol use disorders, we see that disproportionately affects the Latino, or I should say this is women, so Latina community and the African American community. Interestingly, we can still create, we can talk about religion, because when we think about suicide in LGBT youth, we actually know that religion can sometimes be a protective factor. It doesn't necessarily mean that you like your religion and it doesn't cause a lot of other problems, but it keeps you from killing yourself sometimes. So that's actually protective in many ways. So again, important to think about what the outcome is, important to think about who you're working with. Yeah.
Back you up, do you have any kind of breakdown similar to that based upon, say, urban and rural?
So I don't, so for alcohol use, I don't. The data that's, if I actually jump ahead, and we think about stigma overall, so some of the data that's been coming from rural communities versus more urban communities, the benefits of, more, it's not just sort of who you engage with, it's also the legal protections that you can have within urban communities relative to rural communities. And so there's been certain studies that have been done that have looked at rates of depression, anxiety, PTSD in LGBT communities in rural areas that have no LGBT protections versus urban areas that do have LGBT protections. And the rates are essentially about 3 times higher in the rural communities. So that's, again, this is another reason why it's important to keep in mind, we're working with our patients, but we also have an opportunity to advocate at any point. So, the laws matter as well, and we can see that they matter, from a research standpoint, absolutely. And so overall, when we're thinking about interventions, it's also important to think about who are we targeting? Are we working with one person? Are we working at an interpersonal level where we're working more with interpersonal violence, abuse, rejection? Are we targeting a certain behavior that we want to change? And then there's all of these layers of like structural stigma, and I'm sure all of you have come into some challenges within your organizations at times in terms of creating change related to sexual orientation or gender identity, also at the state level, also at the federal level as well. Obviously that will continue to be a problem moving forward, and so knowing the effects of structural stigma on LGBT communities, I really think that the disparities or the experiences from a data standpoint, there's going to be a big bump in terms of sort of suicidality, depression, things like that. So, and it's actually really interesting because the day after Trump was elected, the Trevor Project, which is an LGBT suicide hotline, the Trevor Project received twice as many calls than whatever their largest call day was. So if they had, I can't remember how many it was, but literally the day after Trump was elected, twice as many calls as they've ever had previously. So this is we're going into an area where structural stigma really matters as well, and we need to think about protections, and we need to think about how we change the systems that we can change. I'm just going to skip over this. So when we think about research gaps, that's exactly kind of where we're looking at. We need to do research in terms of how we're meeting the needs of the transgender community in particular. We need to look at communities of color. We can't just have a bunch of research on like white gay people. We really need to have a lot of and that's largely speaking when we institutions that get funding to do research, recruit college kids to talk about stuff, and college kids are disproportionately white. So then we have a great idea of what's happening for white people, and really not as much idea for what's happening in communities of color or areas, low education communities either. So we have to think about that when we're looking at our data as well. So again, the other thing that I think is also really important is that we need to start thinking about move away from this model of saying, oh my goodness, we have so many disparities, which I'm not saying we don't, we do, but we need to start educating people above and beyond the disparities, because a lot of people know about them now. Question is what you do with them, and so we need to work on interventions that really promote healthy coping and promote resilience in the communities as well, because quite frankly, the community is a strong community. It's a thriving community. It's survived through a lot, and so we need to recognize the fact that the LGBT community is a strong community too, and we need to support the strength of the community. But the big question then becomes, how do we kind of translate this to patient-centered care? And so I'm going to talk a little bit more about education. So for those of you that have the opportunity to engage in education or teaching or work at any kind of level, this is the part of the talk for you. But this becomes quite challenging because we know for a fact that when we think about demographics and what makes up an individual person, there are so many different things: race, ethnicity, age, ability status, education level, sexual orientation, gender identity, experiences. There's so much that makes up every individual person. So trying to tease out what could be due to sexual orientation, what could be due to gender-related concerns. These are conversations that, as students, we're not really experienced at having, so they kind of get brushed under the rug. And it's not because people don't care, it's just because we don't teach how to ask it, and we don't teach students how, if they ask it wrong, or if a patient gets upset, we don't teach how to apologize, essentially. And so there's a lot of things that we can do differently in terms of our training. In 2011, there was a big, all of the medical schools in the country were surveyed to see how many LGBT health-related topics do you teach. And all of the schools reported that it was less than 5 hours. The average was maybe 2 hours, and I think about 40% of the schools had nothing. But when you teach about different topics and we break down by topic, you can see that sexual orientation, gender identity, HIV, and STIs, and sex. Those are the things that get talked about the most, which are the things that perpetuate the stigma within the community that all gay people do is just bang and get sick. But this is obviously not true, and the things that really create the disparities in the community, if you think about gender-affirming care, if you think about, gender-affirming care, transgender status, mental health, chronic disease, these are going to be things that create the morbidity and mortality and the disparities that we see in the community, and those are the things that aren't being taught. So the way our education is structured right now perpetuates a lot of the stigma that many individuals have towards the community, and that's really what we need to change. So in the same way that medical health has developed, education has really developed too. So before the 1900s, again, women didn't have sex, men did, and if you got sick, we threw leeches on people. So that's just a summary of the pre-1900s era, briefly. And it wasn't until 1910 where we actually started thinking about how we train providers differently. And so what was first put out was the Flexner report, which says that all medical schools have to have the standardized curriculum. You have to have certain topics in it. You have to know which variety of leech to throw on someone. But of course, as research has grown as well, the amount of education that is expected of people in medicine, and in healthcare in general, has gotten so big, it's unwieldy. So we said at the beginning of every talk, we create these learning objectives. And how many of you leave a talk and go back and look at the learning objectives and say, oh yeah, I met that? Anyone? You guys all did that over your lunch break, didn't you? We don't look at it. We don't look at whether or not we're meeting the expectations of the curriculum. We just don't do it, or we haven't been doing it. And so we have to, in 2002, that was when the American College of Graduate Medical Education said, nope, we're going to start standardizing this. We are going to put competence, and when I say competence, I'll explain a little bit more, but I'm not just talking about cultural competence. I'm talking about competence as a provider. We're going to put that across 6 domains: patient care, medical knowledge, systems-based practice, things like that. And we're going to measure how you do. Essentially, now what schools do at the graduate level, so when I say graduate medical education, that's like residency. You've gotten your degree, and now you're doing your post-degree training, but you're not able to be independent yet. So that can also be applied to individuals who are completed their degree but have hours to go to get licensed. You just have to have some supervision. So again, when we think about competence, we need to think about how to structure things in a way where we can measure our outcomes and we can tackle our training relative to the outcomes that we want to see, and we have to measure those outcomes. So in medical education, and this is also true in nursing education, in physician assistant education, whether or not you have looked at what like the guidelines or the competencies that you were taught in school, there's a rubric for how you're trained and what you have to achieve. And sometimes, and schools now are actually trying to measure this in a way that we can track people's progress of learning, not just in terms of facts, but also in terms of how you interact with patients, what your notes look like. We can do that with sort of the way technology is structured now. But again, we think about these big domains of competence, as I said, patient care, medical knowledge. That's broken down into individual competencies. I'll talk about that in a minute, but competencies that you learn, there are a variety of them. The Association of American Medical Colleges, largely speaking, advocates for, I think there's like 53, 56 main competencies that all physicians have to graduate medical school knowing how to do. And if you can do that, then you have essentially achieved competence at your level of training. But if you achieve competence as a medical student, that doesn't mean you're going to be competent as a resident, much to my dismay. Turns out that's quite true. We make mistakes all the time. Sorry, I was going to make a bad joke, because all of my other ones have been amazing. Sorry. So competence is multidimensional, it's dynamic, it changes with time, it changes with setting, but we can measure it. So when we think about the domains of competence now, largely speaking, again, there are equivalents in nursing. Medical education and nursing education communicate quite readily about how they do training. And so we have these essentially now 8 domains of competence. Patient care, knowledge for practice, interprofessional collaboration is a newer one, but we have to work. I mean, it shouldn't have been a newer one. It should have been pretty straightforward that we work with people interprofessionally all the time. Personal and professional development was another newer one, thinking about unconscious bias, how we address our biases. This is what are the main domains of competence in medical education. And that's been, essentially that's been standardized into what's called the physician competency reference set. These, again, are the outcomes that are being measured. What we did with the Association of American Medical Colleges, the picture's not showing up, I don't think, but we created this guide. It's a huge guide that basically says, this is what needs to be in your curriculum, these are the outcomes that need to be taught. And that guide has been picked up by it was released in 2014. It is applicable across a wide variety of health professions. And it doesn't just say what are the competencies, it explains why they need to be in the curriculum. It provides examples of case-based teaching, so you can do non-didactic teaching as opposed to someone just lecturing you. Overall, there's cases in there that you can use. It's a phenomenal guide if you're in a position where you get to do teaching. So for example, again, this is just, the physician competency reference set. I'm just going to show you an example of what a competency is. So gather essential and accurate information about patients and their conditions. That's a general competency. It's quite broad. Obviously it changes by condition, but you have to be able to have that conversation. And we qualified this by saying that you have to be able to talk to individuals about sexual orientation, sex development, gender identity, gender expression. These are things that we qualified this. And that's more or less what we did, is that so within that standardized curriculum, this one here, within that physician competency reference set, this is the set that all medical schools, again, teach against. What we did was use those 53 things and basically said within the LGBT community, here is how you could measure it if you wanted to. So what we did there really, when we're thinking about change, we worked within a system, an existing system, to work with essentially what they had and how the system is structured. If I threw another 72 competencies out there, no one would pick them up. Medical schools they have a hard enough time measuring 53 of them, right? So we worked within an existing system, and this has actually been taken up pretty widely, and there's a variety of schools around the country that are trying to include these in their curriculum as well. So again, it doesn't take additional time. The approach that we've said just means you need to talk about sexual orientation. So if you have, you get to do cases in school, or you get to read those little prompts and answer a multiple choice question, all you need to do is say that the person you're reading about is trans, or the person you're reading about is gay, and that may or may not be related to the outcome. Gay man walks in with knee pain. Right now, the way it's structured, students are going to be like, oh my God, how does AIDS cause knee pain? I don't understand. How's that? And it turns out that they just hurt their knee. It's fine. But we get to talk about those things, and we talk about those things as being important parts of personhood. And when you have those conversations, competence sort of naturally follows, I actually think. So we just need to talk about it more. I'm going to skip over these slides. So how we measure the outcomes. In terms of medical education, it's a simple question. Who is going to do how much of what, how well, by when? Essentially, medical student, resident, they need to do this specific thing at this specific level, by their third year of training. Turns out, if you change the do to who, it's a really good sexual history tool. So who will do who, how much of what, essentially it's really excellent, really good. Use it all the time. So in this case, who, healthcare professionals, what they need to get through the competencies, and then by when just depends on level of training. You're not going to be able to read this slide, it's too small. My slides are available, or if you email me, I can make some of these things available to you. But again, at the level of training, when someone comes into medical school or nursing school, you sit down in a classroom and you just learn. You learn a lot of material, and so you know a lot. And then you kind of learn about what you need to do in your profession. So I learn how to learn how to listen to heartbeats, and I learn what the heartbeat sounds mean. So I know how to do it. And then I'm supervised, and I have to show that I can do it, essentially. And based on each of those levels, there are opportunities and ways in which we can assess. Most of the time, we assess using multiple choice questions. We can change the level of assessment that we use. Again, medical schools, nursing schools use standardized patients. At Vanderbilt, we created a patient. We did nothing more than just change the fact that we changed her sexual orientation from being straight to identifying as a lesbian, and it led to so much great discussion within the medical student level about health disparities. So again, very simple, but you can change the way you evaluate the outcome. And you just have to use, again, in the same way that we think about those old Kinsey reports, et cetera, they're not very reliable. So if I'm like 70% gay today, in a year, maybe I'm 50% gay, it's not a very reliable instrument, right? So we have to use measurements that actually assess the outcomes that we're looking for. And so this is a challenge. It's the challenge of medical education. It is a challenge of health professionals education. We are actively working on this at all levels, not just with LGBT health, but there are ways in which we can do it that make sure that competence, not just cultural competence, but competence with LGBT patients, medical competence with LGBT patients is a core and standard part of every training curriculum. So that is a hope, that is a long-term hope for the future. There's some really cool projects going on. So the University of Louisville Medical School, they actually created what's called the equality curriculum. They measure the outcomes with standardized patients. They just took a couple of the competencies and are following students over time. But they're measuring the outcomes, and it's awesome for them. They actually got some grant money for it to do it, and they're publishing papers on it. So it can be a profitable endeavor too, because not a lot of places are doing this. So if you think about how you can do this, again, it's great if you think generally about cultural competence and how you can make your institution more welcoming. I appreciate, how many of you survey patients to say how LGBT friendly was my clinic? Okay, so a lot of you are collecting the data, a lot of you are looking at the data, and about 0 of us are asking the patients how welcome they feel. So that's a good example of how what we're doing and how the research that we're doing doesn't really trickle down to, do we know that communities are being served? So again, outcomes matter, and when you think about the changes that you make within your organization, think about the outcomes that you want and measure those outcomes. So how do you do this right now? So again, there's a lot of stuff, there's a lot of changes that could be made. Take one small step at a time. Every step matters. Eventually, we'll get further and further, and we'll have really good health care for, well, actually, I lied. It depends on if the Affordable Care Act changes or not. Then we might not have good health care. But in terms of right now, you guys, it's not, well, it's a joke, but it's really not, I guess. Isn't it? Thanks. Actually, that's cute that you guys didn't laugh, because you're like, oh, this is serious. We can think about, again, if we're thinking, we need to think sort of more broadly about healthcare organizations and healthcare systems, and how, when we think about healthcare systems, we're not wrong. We think about them as businesses. They are businesses. Everything runs on money. We need to think, if you want to create some change, you have to think about how you want to monetize what you do. Or you have to think about, all healthcare clinics have to meet certain standards. You have to find a way to sell this to your organization, and that's going to be money, or it's going to be, if you don't do this, you're going to be shut down. That's because it's going to keep you from making money. So that's in many ways, and then the rest of us who are engaged in healthcare, we do this because we care. We care about communities. We care about patients. And the people who run the businesses do too. But overall, the business is the business. And so we need to think about how we can change that. So this is where community engagement and advocacy comes in terms of thinking about, and this, I think, the community partners piece is the most important, because again, the outcomes that we're looking for happen in communities. So we need to be able to survey our communities, know what our communities need, and make solutions to deliver and address that need. If we don't have community partnerships, We can't do that. So those community partnerships are absolutely, absolutely critical. And you have to make sure too, I think as more and more people, as this topic becomes more and more prominent, people want to hear, get more and more training. Again, you're all getting like continuing education credits for meeting objectives that we don't know. So again, we don't, I don't know if this is going to translate into patient care at all, but we should measure it. But again, in terms of community partnerships, we survey the community, and then we have to measure the outcomes in the community, and we develop interventions around the community. When the community is very hesitant to engage in healthcare, and the trainings that we do oftentimes ask patients to be on patient panels, or the community health centers get a lot of requests for training or a lot of requests. We are asking people who work in nonprofits, asking people who don't make a lot of money to come and help teach us, so that we can get continuing education credit. Those community partnerships over time continue to, again, create an us versus them dynamic. Those community partnerships have to incentivize and thank the people for coming and spending their time and working with us. This is not, people can't work for free. And unfortunately, what's happened in LGBT healthcare is a lot of people do this out of the goodness of their heart. And so if you're doing a training with an organization and you're having someone come and speak, I really encourage you to think about what could you offer the person aside from, a free lunch or something like that. So those community partnerships are really valuable. And so I'm going to talk a little bit about a community partnership that we developed at Vanderbilt that we called the Trans Buddy Program. So again, one of the biggest disparities that we have is not necessarily in the healthcare outcomes for LGBT people. It's in the fact that they have trouble accessing care. You don't get into the health, you don't want to show up, you can't find a sensitive provider, but so in turn, you don't get health care, or you show up to the emergency department when you really, really, really need it, and that's not good preventive medicine. So when we think about what is going to make centers more welcoming for people, what we did with Vanderbilt is, we have a volunteer program where patient liaisons, come in, help get people around if they want, someone to help them get around the healthcare center, if they, or getting in touch with a provider. We have these patient liaisons. What we did is create a system, adapted the system that they already have, and basically said, could we have a subset of these individuals who are trained in working with transgender patients? And they were like, yeah, sure, if you do it for free. So we're like, okay, we'll do it, because it's really important, again. So we developed this training and provided it to a number of individuals who expressed interest in learning how to work a little bit more, interacting with the healthcare system when you're gender nonconforming or trans. How can you make that encounter not as difficult? And so we had a hotline that people could call if someone needed to go to the emergency department. We'd get someone there right away. If someone actually just wanted help at an appointment 3 weeks down the line, we'd put it on the calendar. And so if a transgender or gender nonconforming person wanted assistance interacting with the healthcare system, we created this buddy system to do it. We did that we wouldn't have been able to do it actually without community support. So we had individuals from the community help us create the training that we did, and then they also helped us disseminate the word to people who were in the community in a variety of ways. So we just worked through existing networks that we already had to get the word out. It was founded, I think, in 2015, and since that time, we've had over 100 calls, which again is a lot, all things considered. When you ask for, like, how many of you have asked a buddy or just a random person for help going to the doctor? You typically don't. So 100 calls is actually quite a bit. And they're trained to help out along the way. So like if there's a lot of, again, the number of people that you encounter before you get to your doctor, from the parking attendant, to random people in the cafeteria, et cetera. There's a lot of people you encounter, and so we have ways of working with the buddies to be supportive across all of these levels of the encounter, and we provide referral resources and medical resources as well. And so this is a great way, a great intervention that has a lot of institutional benefit. We have improved patient-centered care in many ways towards the transgender community. We're working with an underserved community. We are measuring our outcomes, and it's creating a tie with the trans community as well to say at least that if you come to Vanderbilt, you will be sort of essentially the care that you're going to receive is going to be quality care, and your experience is going to be one that isn't so absolutely painful. And then the community benefit obviously kind of goes without saying, but there's reduced isolation. You get empowerment over your healthcare decision making because you have someone that can help advocate for what you need and feeling that they're welcome there, essentially. So overall, that's just one example of how we can kind of create change working within existing systems. Change is obviously a slow process that happens over time, but there's a lot of ways in which we can create change. We can work with allies within the communities and within systems and leverage the resources that we have to really try and push systems in the right way. So with that, that's my talk. Hopefully it was okay and the jokes weren't too terrible. Are there any specific questions that you guys have? Also, what time is it? Oh, do you want to clap? That's fine too. Thanks. What time is it? Do we have time? Oh, okay. Well, if you want a stretch break, you guys can take that, but I'm also happy to address any questions that you guys might have at any level. Yeah. Oh, no. Okay. Oh, there's a mic. Ah.
Guy. I guess, have you seen this type of a program, your Trans Buddy program, at any other institutions or something similar to that? Love to see it at, I don't know, Penn State or out here somewhere.
Wouldn't you love to see that at UPMC? Yeah.
So you can leave your toolkit or whatever you do.
Yeah. So actually, this is kind of cool. We'll see if it materializes or not. I hope it does. But UPMC is aware of this program, and we've talked to them about it, and we'll see what comes of it. But hopefully we can get something similar, at least at UPMC as well. In terms of other programs that have modeled the Trans Buddy program, University of Pennsylvania now has a program. Mount Sinai in New York has a program as well. Another local community hospital in New York has a program. UCSF out in San Francisco has a program. And all of those programs have sort of sprung up after we created our program. So other people are doing it. It's a very easy thing to do, in all honesty. It's very easy. And so it's a very easy thing to replicate. But yeah, there are other programs that are modeling it. Yeah.
So for your Trans Buddy program, those individuals that were the volunteers or the liaisons, are they peers? Were they laypersons? Were they medical professionals? Or is it a little bit of everything?
No, it's a really good question because, again, it gets back at who's doing the work. So what we did is actually have, there were members from the LGBT community who really wanted to get involved in LGBT health in some way. We invited them, and the Vanderbilt University Medical Center invited them to be patient liaisons. And so, they got really ugly blue vests that had like smiley faces on them looks like he worked at Walmart, but they were invited for a special training, and so they were able to get involved. And we just sort of, they had people available. We worked with Vanderbilt to create a calendar to make sure that people were available when people had appointments, essentially. So if you, the biggest challenge with it is if you want to, it's great if you can get notice in advance, but sometimes people come into the emergency department and that requires people being on call. We found it really helpful to have an on-call system. No one ever really called, which is great, but we created that because we felt it to be important. That obviously was really powered a lot by the community members who were invested.
So then just a quick second follow-up. Does the model work best when they are their peers from the LGBT community? Have you looked at using others that may not be as culturally competent outside their peers?
Yeah, also a really good question, because it's really getting at, meeting up with this stranger and sort of saying, hey, how's it going? We used LGBT, actually not everyone identified as LGBT. We identified people who were very clearly allies of the community, essentially. I think the way that one does that is, you solicit interest, see who's interested in doing it. If you don't have interest within the existing pool of people that you have, if people aren't interested, we can do a training, essentially, and think about, what it might take to get someone from point A to point B in a personalized way. And then you have to, I think the other big thing that is super, super, super important is it's so great to have a resource, and it is also really crappy if you don't advertise your resource. So that's the other big thing, is that how you get the word out to the community. But I think people would still be hesitant to come to healthcare if, period. I think it's helpful to know that the individual is an ally in some way, shape, or form. I don't have any data to support that.
Thank you.
You talked a bit about medical education and medical schools, and historically there's been very little LGBT content in medical school curricula, but it has increased a bit over the past couple of years. Are you aware of any model medical schools that have gone beyond like what we're seeing kind of across the board, like 4 hours or so, almost all still devoted to HIV? Like, are you seeing any medical school curricula that might include fellowships or residencies that are including LGBT health, or that are kind of going beyond only a sort of a narrow look at sexual health?
Yeah, no, it's a wonderful question, because you touched, I think, on two very important points. One is what happens after medical school. The other is, are there places that you can model? In terms of the first question, medical schools that you can model, there's a variety of programs. I think NYU, one of their family medicine doctors oversees a curriculum. His name's Richard Green. They used to have a certificate program there. I'm not sure if they do anymore. Yale developed a new curriculum as well over the past couple of years. University of Louisville in Kentucky is a really good school to model in terms of evaluating outcomes, because they've put a lot of thought into their assessments. I actually think with the way that things are going right now at Pitt, we actually have a fair amount, like definitely more than 5 hours in the curriculum. So there are a variety of schools that I think are doing this well. Obviously, one of the biggest barriers is like, you have to practice something, and one of the things that is quite difficult is if you're a medical student, we have to create elective programs so people can travel to places that have LGBT health centers. So we have to, again, start funding programs like that. In terms of fellowships and residencies, there's not much, to be honest. There's really not much. I mean, I'm in psychiatry, and you'd think we'd have a lot in psychiatry, and we really don't. So once you hit the graduate medical education level, Again, it's nice to know about it. If you don't come across LGBT patients and practice it, that's going to be a problem, and obviously that's going to be, your exposure depends on the area of the country that you're in. The one program I know that does a good job is actually up at the Brigham and Women's, has an HIV LGBT fellowship track for individuals in internal medicine, where they spend a year doing work at Fenway and at a local HIV center as well. So they get accredited in that track. Well, you guys are free to email me at any time. I'm happy to talk about any of these topics, both by email or if you want to chat after, well, now. I'm happy to chat a little bit more. But again, thank you guys. Thank each of you for coming.